Good morning, everyone. Yes, I always say I am not a morning person, and these presentations are always morning presentations, right? But you all are like bright-eyed and you're smiling, so I think together we're going to get through this. I am a very interactive presenter, so like if I ask a question, feel free to just call out an answer, say your thought or your idea. But I thank you for your dean, your associate dean for research, Margaret, Barbara, for those who invited me to be here. I'm really excited, and I'm most looking forward to our Q&A time so I can just hear what's on your mind, right? Questions that you may have or things that you've done successfully that we can all sort of like learn and grow from. But I titled this Bitten by the Bug because research was not always a love or a passion of mine. So this is like 3 or 4-year-old Bridgette. She did not know that she was going to get a PhD or become a professor, or you all will be the first place where I am like personally publicly announcing this. As of June 1 of this year, I will be the new Associate Dean for Research and Innovation at Villanova University. So yes. And you're clapping, but why that's absolutely hysterical to me is I hated research. And I'm not joking, I hated research. Do we have any of the BSN students here this morning by show of hands? No, okay, I was gonna tell them, oh, we do have someone? Hello, oh, you woke up early. Let's clap for her, yes. But when I was in my undergraduate program, I did not, and it was no fault of my professor, so I'll say that for those of us, because I teach research now. But I didn't get it. It didn't click for me. And so I'm like, p-values and test statistics and, crunching numbers. It wasn't something that I ever desired to do. I wanted to be a NICU nurse. And in my mind, I was going to go into the NICU and work that to the end of my days and retire from that setting. But this little girl, even though she didn't know anything about research, even though she didn't really at that point yet know anything about nursing, I always knew that I wanted to do something to change the world. I had huge aspirations, and my parents raised me. There was no such thing as a glass ceiling because it was like, you do what you want to do. You get the knowledge, you get the skills, we pull together the resources, and we make it happen. And I grew up in Brooklyn, New York, so that whole hustle and grit of getting things done. But as I continued on my journey, I was exposed to more. I got to travel internationally, so doing some work in Dominican Republic. I lived there for 3 months and seeing what was happening in Haitian refugee populations or different things that were going on. Doing some capacity building work in Botswana, but then also some local things in Philadelphia. I started seeing that we had a lot of problems, right? And it's okay, I'm in the NICU at this point. I was seeing bedside clinical problems, but I was also seeing how what our patients were experiencing wasn't only driven by their beliefs or their behaviors or what they were doing, but there were broader influences. And at that time, I wasn't calling it social and structural influences, right, as we do now, but I knew that there was more. And so there is this quote by Ida B. Wells that says, "The way to right wrongs is to turn the light of truth upon them." And if you don't remember anything else that I say today, our privilege as nurse researchers is to shine the light of truth upon whatever, right, our issues or concerns are. So if you're doing clinical care, if that light of truth is the fact that some patients are receiving higher quality care than others, or if you're working in more community and public health spaces, if you're looking at oppression and marginalization and how that affects people from having the resources that they need to be healthy, I want to encourage us to remember that our data can shine the light of truth upon injustice. And I want to challenge us beyond that we have done an excellent job of describing, right? We can say blacks are this and whites are this and Native Americans are this and Latinos are this. We've said it enough. Now that we know that, how do we translate that, right, into something that's actionable? Because people should not continue to die because of the color of their skin. They should not continue to die because of the neighborhoods that they live in, and those neighborhoods are not by choice, if we think about it, right? If you know about mortgage redlining and other historical practices that have taken place. So we are really at a key and pivotal time in our nursing history. I was saying at dinner last night where like the momentum is there. The resources are there. You know, how many of you, by show of hands, have been doing like health equity or health disparities work for a while now? Yeah, it wasn't sexy before, right? when we were trying to do this stuff 15 years ago, literally the NIH did a study, and if your proposal had words like equity or community or adolescence, our studies were less likely to be funded than some of the other work. Now, if we were doing biomarkers, so you had everyone like, do we just like swab a cheek now if we want to learn more? And it's like, there's no need for you to swab a cheek because that's not part of your research question, right? And so I won't do my soapbox, but I think we are in a reparations, that's a curse word, right? But like a reparations period of nursing research where now we're saying, you know what? Yes, we need the biomarker research. Yes, we need the behavioral research, but we also can no longer ignore the fact that racism and poverty, right, and the way that we mistreat people who migrate and immigrate to this country, all of those things matter, and people will continue to get sick and die unless we start to tackle those root issues. And one of the core tenets of our profession, right, when we think about who we are as nurses, is advocacy. And so when I say, you know, like using research as an advocacy tool, we can use our data to advocate for populations, and we don't give them voice, right? Because that sounds very like maternalistic and we have the power and they don't, but we can absolutely elevate the voices of individuals who have been absent from tables and conversations. So that's my initial disclaimer so that you can have a sense of who I am, why I'm up here. Any of the crazy things that I say counted to me and not to your planning committee, because they're probably, but I want to sort of walk you through kind of a journey of how even I have evolved as a scientist, and some of it you may already be working in these spaces, and some it may challenge you to think through how you can take your own work to the next level. So language matters, right? And when we talk about inequality, right, when we're saying that people do not have equal access to things, that there is unequal access to what's happening, equality then sounds good because we say that we will then evenly distribute, right, tools, resources, assistance. But if you look at the graphic, your bottom left quadrant here, if we're talking about equality, what do you notice about the character on the left and the character on the right and their ability to get apples? What do you see there with equality? Say it a little louder for me. It's not equal. So equality is telling us we're making it equal, but in fact, it still is not equal because we gave you both a ladder. That should do it. You needed a ladder so that you could be closer to the tree to reach the apples. But if you notice, which side, the left or the right, has more apples? The left has more apples. So not only does the left have more apples, but the left is also given a ladder that helps them access those apples. The right was given a ladder, but the ladder did not help them get access. Equity says to us, okay, well, let's customize the tools and the resources. So not only will we give you a ladder, but we'll give you a taller ladder because your side of the tree was leaning farther away from you and you weren't able to reach it. But what do you still notice with equity? What's still happening? Still not enough apples. The tree is still leaning away, right? And so you have access, you have customized access, but something is still off where you're still not being afforded the same opportunity. And so for the past almost 20 years now, most of what I have done has been in the equity space. And equity is good. I'm not saying that we want to abandon any of this work, but where justice now steps in is justice says, let's not only give you the tools and the resources, but let's fix the system that creates the inequity. So let's get this tree straightened up. Let's make sure that there's enough apples on both sides, right? And when we look at this, let's say in terms of healthcare, it's not just ensuring that you have a health center in your neighborhood, right? If that health center is not providing high quality care, if it's not offering care during hours where, you know, if you're an hourly employee, you have to take off of work. How many of us are salaried here? Right, majority of us. Every time I ask this, it's so funny because people are like, where is she going? I don't know if I want to say, you know, like maybe I'm salaried, maybe I'm not. We're salaried people, we are salaried, right? So if I have to make a doctor's appointment, I make that appointment and then I go. I don't lose wages to go to my provider. But someone who is hourly loses wages. And if they have to take a bus and a trolley, you know, and all these modes of transportation, or if they have to pay for car service to get there, putting that health center in their neighborhood or close to their neighborhood doesn't necessarily address the system. And so I would love for us, as we're designing our studies, if we take both equity and justice lenses to our work, right? Then we begin to ask the questions of which system is broken. And what I love with that question, if we think about it, these systems are not broken. They're actually doing what they were designed to do. Our healthcare system is an illness system. It's not a wellness system. And it is doing what it is designed to do, which is to make money. And if we as nurses continue, mini soapbox. If we continue on this value-based care wave that we're going on, and if everything is a price point and a dollar that we can put something to, somebody's ability to live or die should not hinge on how much money an insurance company can make or a hospital can make. Like, we are failing as a nation. We tout ourselves, right, to be like the best, and we're so developed. We're not even in the top 30 countries nationally when it comes to these different health indices. Universal health care, right? Like, until we get there, everything that we're seeing right now, we're going to continue to see. But I'm going to come off it because it's going to detract from however many minutes I have left. So for me, my central passion is to use research as this advocacy tool to change the world one community at a time. And to stand here, I won't tell you all how old I am, but to be X number of years, post the picture of young Bridgette that you saw there, and to be able to like think about a research study and get it funded and put it into action, that part is great. But what helps me sleep at night and what brings me the greatest joy is the impact of doing that work, right? Like, if it just makes life better for one person, then I feel like I've done what I've been called to this earth to do. And I encourage you, when you think about the exponential impact, right? I love this image because one person, each of us by ourselves, we can only do so much. But what we do, even if one of you leaves today thinking about something differently, you're connected to 2 other people, 30 other people, 100 other people. So we start to see this ripple effect from our work. And so I challenge us to think about how our research can reach places that we never even set foot in. Whether that's like today, doing symposiums for Research Day, sharing the work that you're working on, thinking about non-traditional partners. I'll get into that in a little bit so that we can start working with people who we historically haven't worked with, right? But that is how we're going to be able to address inequities. That is how we're going to be able to move the needle so that people are not dying unnecessarily, because at the end of the day, that's what this is all about. People are getting sick and they are dying and they don't have to, and we as nurse scientists are in a position to do something about that. So when we think about community, before I get into these community-based research projects, I want to sort of define what I mean when I say that. And so for me, community is like groups of people who share these common characteristics, and they're not bound by space or time. So it's not going to be static. You know, you can have a community of nurses on a unit that you're working with. We have digital communities. I have a colleague, Dr. Robin Stevens, who's out in California. She does social media research and health communication. So thinking about, especially, how many of you, by show of hands, are working with youth? Yeah, so for those of us as youth researchers, the brick and mortar things, they're there, but we have to engage them where they are. And social media is so ubiquitous right now, so how do we leverage that for interventions, right? But those are digital communities. So we want to consider that and realize that the historical or traditional bounds that we've had on what it means to be in community or be part of a community have changed, and we want to make sure that we evolve with that. So if you design the best program, you have this amazing intervention, you've done your research, you know what the driving factors are, and you say, this is what we need to help you, right, to your population that you're working with. If you build it without them, will they come? People are shaking their head no. And why not? Why won't they come? Because you didn't engage them? And I heard something else. Was that you, Erica? It's not for them, right? Because even with our best intentions, I, as a Black woman, I'm a millennial. Isn't that hilarious? Like, by age, I'm technically a millennial. I think it's so funny. But like, even though I occupy this space as a Black woman millennial, if I want to do something for other people who look like me, my lived experience is still going to be different from theirs. And even if I go and I get people who grew up in Brooklyn and now live outside of Philadelphia, I still can't say, I am you and I know everything that you need and everything that you want and here you go, right? That's disingenuous. And so if someone said to you, oh, I have this great opportunity for you, I'm bringing it to your doorstep, it's everything you need, just do it, here you go. Are you gonna do it? No, because you're like, you don't even know me to know what I need, and you didn't ask me if I wanted what you're trying to give me, right? Like, you don't even know if I like this. You don't know if it's tailored to me. So when we think about our programs, when we think about our interventions, if we are building them without the people that we're hoping that they're going to help, we're like cutting our feet off, cutting ourselves off at the knees before we even get started. And so I also encourage us to really, truly engage communities. When do you think this engagement should start? Say it again. At the beginning. And when would you define beginning?
After there's a concept developed, and then get input from there to expand on it.
Okay, so she said after a concept is developed and get input from there and expand on it. And yes, and that's one way to do it, and I think that's how we've been doing a lot of our scholarship. But what if we go to them before the concept is developed? What if we say, hey, these are some ideas that I've been thinking about. Are you seeing the same thing? Is this a priority for you? How we're thinking about addressing it, does it make sense? Or do you want to do something completely and totally different? Right? And being able to be okay with that as the PI to say, okay, this is my lane and this is what I do, but I can also leverage these same skills and expertise that I have, and I'll show you in a moment. I started out as an HIV STI researcher, laser focused, right? Like from the NICU to HIV, and people are like, how do you make that jump? Sex, right? Like, sex gives you babies, and sex could give you HIV or STIs, right? But like, so that was the common thread there. I'm sorry, y'all, I'm like a comedian. But so when you're engaging in these spaces, and then I'm talking to people, and they start saying, well, like, yes, that's an issue for us, but heart disease is also a problem. Or if you've seen what's going on the news with gun violence in our country as a whole, right, like mass shootings, all of these things, Philadelphia right now is alarming. And so they're saying, like, yeah, all these health things are, important, but violence is also a public health issue. Like, right, violence is health. And I know you have some faculty here, Dr. Lucy, who are working in the violence spaces. But so as a researcher, I had to grow and evolve, because if I'm going to call myself a community engaged researcher, if what I want to study is not of importance or not a priority for my community, I can still take, right, these skills that I have to pivot and address other areas too. So where community engaged research becomes really beneficial is we have this authenticity where we're coming and we're saying, this is who I am, this is what I can do, how do we now work together to address the things that are important to you? And then we have buy-in, right? You all were saying they're not going to come because they don't feel engaged, they don't feel a part of it, they don't feel ownership in it. If we're telling them what we're doing and how we're doing it, that's really coming across in a very pejorative way of like, I know what's best, here you go, versus you are the expert in your life experience. This is what I'm thinking, this is what I've learned, this is what I've done and can do, and how do we now bring these things together to make a difference? So I'll walk us through a few examples from some projects that we've done in Philadelphia. First was trying to get at, the social and structural context that health behaviors were occurring in. And so I want to read this quote to you. We had gone to the National Museum for African American History in DC, and it talks about place matters. And sometimes when we say that, it comes across in a very negative tone because we're typically talking about the disadvantage in a place or how, poverty is concentrated. But in this, it says, place is about geography, but also about memory and imagination. People make places even as places change people. Places are secured by individual and collective struggle and spirit. Place is where culture is made, where traditions and histories are kept and lost, where identities are created, tested, and reshaped over time. So even though for funders in particular, right, we have to say what the problem is and we're throwing in the statistics for how everything is bad and wrong and needs to be improved, we don't want to lose the fact that there is still hope in place. There is still resilience in place. And even when we're working with marginalized and oppressed, groups and populations, they have thrived, they have survived. I love how the dean in the opening, when we think about the land that we're even on, look at now, all of these years later, population groups, despite genocide and so much that has happened, they are here and making it. So while we look at the disadvantage and the things that can be wrong with place, from an assets-based perspective, we can also look at where place can have positive aspects, right? Where there's that collective spirit that comes through. And so this image here, what do you see in this picture? What did you say?
I said St. Paul, Minnesota.
St. Paul, Minnesota, yes. One time I showed this and somebody was like, I see a new alignment, I see new tires, right? It's like, if you hit this, the fender is gone off the front of your car. But we were doing HIV STI work with young Black adolescents aged 14 to 17, and we're talking about condom use and partner negotiation and HIV STI knowledge, and they are talking to us about bigger things than that. They're like between the ages of 14 and 17, they're understanding, they're grasping, they're seeing how they can live on a street where this pothole could be there for months, literally months. And for those of you in this area, right, you see it for months, but they know that if they go 3 blocks around the corner, sometimes only 1, that pothole will be gone before the next morning comes. And my husband and I, this was maybe sometime last year, we're driving home. We had since moved out toward Villanova. And he comes around the corner and hits a pothole. And we're like, oh man, the township needs to know. Do you know by the next day that was gone? Like paved over and gone. So there's power, there's privilege, there's resources, right? But so when we think about how neighborhoods affect health, a pothole does not give someone HIV. Unless there's like a needle in there, right? Like, oh, whatever, right? For the person who's like, well, it could, no. The pothole by itself is not going to cause someone to contract HIV, but neighborhood condition, if that is internalized as people don't care about me, what do they think about me? I'm being mistreated, right? And like someone else is getting more than what I have and it's unfair. That being internalized, it's the psychological pathways that neighborhoods can operate through for the intrapersonal parts of it, right? But then also when we think about like built environment and access, those things matter too. But here they were saying, what do they really think about me if my street can stay like this for months? So they were getting it, and they might not have been able to articulate to say, oh, my neighborhood being this way makes me think this way about myself and about relationships. But even at ages 14 to 17, they knew that it was unjust. They knew that it was unfair. They knew that something was wrong. And so when we took these data, we also had a focused conversation with some administrators, direct service providers, community members that were in one of our neighborhoods that was most heavily affected by HIV and AIDS. And they were talking to us about some like individual social and structural factors that were driving our local epidemic. And one of the things at the individual level that they highlighted was that this stigma, right? That even if people were positive, they would not want to disclose that to their partners for fear of retaliation, right? We had people where one of the young women, her partner, when they broke up, put her face, like put her picture on flyers and posted it all through the train stations, saying, you know, like, she's dirty, she has HIV, don't be with her. And so that stigma is something that's real. At the social level, they talked about how if you have partners that are more likely to be selected from certain groups, either near where you live or of a similar background to what you are, then your risk for HIV could be higher if those individuals are from groups where there's just more concentration of HIV, right? And then at the structural level, this one, and I love highlighting this, if you are this reviewer, you don't have to like disclose that it was you who reviewed the paper, but when this was under review, we had the language in here that said the hyper-incarceration of Black men was driving our local epidemic. And when you hear hyper-incarceration, what does that make you think? Too much, disproportionate, right? So the reviewer says, to say hyper-incarceration makes it sound like Black men are being incarcerated at a rate disproportionate to the crimes that they're committing. And I was like, thank you, because now, copy, paste, like put that in the paper, because that's what was happening, right? And still is happening. And I will not do that soapbox because we won't get through any of the rest of these slides. But I wanted to share that example because sometimes when you know something is right, you have to fight for that. And it doesn't mean that the reviewer was bad or wrong, right? But that was also an educational moment for this individual because if you're not living this life and in these shoes, you may not know that. If all you see is the statistics, then it looks like Black men are doing everything that the world is saying that they're doing. But when you look at it to see, you know, stop and frisk and all these other policies that were put in place to continue to oppress and marginalize, and it's like, oh, wait a minute, something else is going on. And we also had to do a similar thing for our work with youth. We were working with 3 separate IRBs. Total nightmare. If you don't have to do that, don't. If you do, just like if you drink wine or coffee or draw, like whatever your happy place is, make sure you get to go there. But our youth were telling us, you know, we can get mental health treatment on our own without our parents, and we can get HIV STI testing on our own without our parents. And so if they have to consent for us to be in your study where you are working with kids who are having sex, like if we have to do that, we're not going to participate. So we published the paper. It was this whole uphill battle to get the parental permission waived so that young people could have access to this intervention. So fight and advocate for your populations, but be ready to like de-stress yourself because it's hard to be, you know, this champion and this advocate. But the more we were seeing the role that place had, right, how we talked about those more like negative influences of place, the more we were seeing that, I came up with this concept of geo-behavioral vulnerability to HIV. And this says that it's not just what you do, but also where you do it and with whom, right? Statistics are tricky because numbers by themselves do not tell a complete story. And this is why I'm a mixed methods researcher through and through. So if we look at statistics alone, it will make us think that particularly Black and Latino populations are riskier, are having more sex, are having unprotected sex, are not getting tested for HIV and other STIs. But when we look at the numbers, that's actually not the case. They are engaging in more protective behaviors than other populations, but what is happening is this geo-behavioral vulnerability. So if I live in a community, and this is my husband here, I'm using this, it's not really what I was out here doing, but I'm gonna just do it as an example, okay? So if I'm in a community and only 1 person per 100,000 is HIV positive, I can have unprotected sex with 600 people, right? Laws of probability, what's the likelihood that I might acquire HIV? Small, right? I was wanting like an epi or a stats person to be here to do that math really quickly. That would have been cool. But it's gonna be very low. But if I live somewhere and HIV case rates are 60,000 per 100,000, and I have unprotected sex 1 time with 1 person, I am exponentially more likely to acquire HIV than the person in the first scenario, right? and I was not more risky than that person. And so when we talk about how language matters, it's not just what people are doing, but it's the role of geography, right? That's also playing out in what people are doing. And so when we then think about that, we had gone into 4 census tracts in Philadelphia. And this is where, for me, GIS mapping, like, so I love words, I love numbers, I love, like all of that. But maps just make your data live in a way that other figures or tables can't. And so what you're seeing here, the 2 columns on the far left are predominantly black census tracts. The 2 on the far right are predominantly white. And then the darker gray shading is where we have higher HIV incidence. Each of the dots that are on here represent different structural indicators of disadvantage. So we had narcotics violations, disorderly conduct, and then vacant parcels. And as you're looking at this map, just call out something that you notice in the darker shaded areas on our map. More dots, less dots. More dots, right? So we have higher indicators of structural disadvantage in the areas where we're also seeing more HIV burden in that particular population. Now, if HIV only trended along racial lines, which we thought, for so long earlier on in the epidemic, our predominantly white neighborhoods, regardless of the social and structural conditions, should look the same, right? But what we're seeing in these higher HIV incidence areas and the predominantly white community, the structural indicators are there as well. And so it's letting us know something is going on that's outside of the individual, that has nothing to do with the color of their skin, which we hopefully all know that race is a social construct, right? And it's racism, not race, that's driving the health inequities that we see. But where I really also started to get interested was what is happening in community A, where it is a predominantly black tract, but we're seeing lower HIV incidence and lower structural indicators, right, of disadvantage. And so this is where we take our work and we say, all right, how do we now pull on the strengths? What's working well? Well, one of the things that this community had is a lot of green space. Another thing that this community had was very engaged and involved neighborhood networks, so that collective efficacy, right? Those things were there. And this paper, this one and another one, we did this community ethnography, which was really cool, of just like going in and talking to residents, collecting artifacts. But if we just had the quantitative data or we just had the qualitative data, it would have been harder to get that complete picture. We then went and looked at secondary data on cases, so those who were HIV positive in these demographics. And part of the things that really stood out was what was going on in the predominantly black tracts. We wanted to see, do these transmission indicators differ, right? So are people more likely to acquire HIV by injection drug use, heterosexual contact, or male-to-male sexual contact? And what we ended up finding, are any of you familiar with the concept of microepidemics? So it's like you have HIV as an epidemic, but then within the HIV epidemic, there are subpopulations that are also affected. And so nationally, injection drug use and HIV, we've been able to do by leaps and bounds with syringe exchange programs, right, and a lot of different things. We've seen those rates come down. We're seeing nationally that men who have sex with men and our transgender populations are like lion's share disproportionately affected by the epidemic. But what's happening in Philadelphia is this microepidemic in heterosexual populations that if we only look at broader data, they will be missed. Or this microepidemic among those by their insurance status, right? Whether they're more likely to acquire HIV from sexual contact or injection drug use. And so these data really helped us to emphasize policy for resource allocation to make sure that we are turning the light of truth even for populations that may have fallen by the wayside, in national conversations or different things. But just showing this to say we can use our nursing data to even elevate, issues and concerns for populations that may be missed in the work that we're doing. I am an interventionist at heart, so if I see something is wrong, like I'm a doer, I'm a fixer, it's like, okay, what do we do to address this? And so we got into some work to try to now, with our young people, look at their risk for HIV and other STIs, but also bring in the fact that they're dealing with these bigger social and structural influences on their health. And so Project Gold, We Are Kings and Queens, is an intervention that we came up with in partnership with young people. They actually developed the logo for this, the slogan, like everything. It was a very iterative process with them. I acquired, that's me on the bottom right, I became a street artist, so like learn how to, do some chart, I can't even say it. Chalk, there we go. Sidewalk, chalk, never mind. I drew a frog on the sidewalk. There you go. But what I love about this project, this for me was an example of how our research can be bigger than we've ever even imagined. So I went into it wanting to make a difference for young people who were, acquiring HIV, acquiring other STIs. This ended up even making a difference for our project team. I am a mentor at heart, and so anyone who works with me, I'm always asking them, like, what are your goals? What do you want to do with your career? Where do you see yourself in the next 5 years? And so if you're not doing that yet, I encourage you to do that with your research teams and your staff. But we had people from this go on. One is a lawyer, 2 got PhDs, 1 is currently in her postdoc, another is a research project manager, and I had high school students through postdocs working on this. So the fact that 2 of my high school students went on to get PhDs, and I'm not saying that like it wasn't me, I'm not taking credit for it, but when we think about research and pipeline, right, and getting people in, they were exposed to research through Project Gold. The light bulb went off for them, and I was like, you know what, like God does all things well. So I hated research, but now it helps because when I talk to other people and they're like, oh, I don't want to do that, it doesn't make sense. And I'm like, ooh, come here, and like come in a little closer. And I can share my story to say it didn't make sense for me either. They had so much fun, we all did, designing this intervention that they were like, they called me Dr. B, like, Dr. B, how do we? Like, I want to be able to do this. And I'm like, funny you should ask, like not only do you get a PhD, but you get your nursing degrees, right? Like you do your PhD in nursing. But yeah, so this morphed into this like huge thing. This activity here, though, was designed by one of my undergraduate students. So we wanted to have something where they could look to see how decisions would be made. And so we came up with this decision tree. This was a small group intervention. And this poster would be on the wall, and the lettering that you can see would be covered over. And as they got to each decision point, they would have to say, it's like the first one for Steve. He has, his girlfriend Maya is over, they're watching TV, they're kissing. He does not have a condom, and he has to decide what he's going to do next. And so we had the language to say, does he have sex with her without a condom, or does he not? And the kids are like, Dr. B, everyone is going to say he shouldn't have sex with her without a condom, because that's what they're going to say. And they were like, but in the moment, that's not actually what they're going to do. And so again, the importance of having community in the process, right, in the concept early on, they then said, you have to make it trickier. You have to say, should he keep kissing her or stop kissing her? And they were like, because you want to show how one action, right, you don't have to self-disclose if you've ever had sex before, but one action can lead to another, right? And so they said doing it that way, and then it ended up like working beautifully in the groups where we got to show them how if you continue to keep kissing this person knowing that you don't have what you say you want for your safety plan in place, you could put yourself at risk. And then from the conversations that we had with them, where things like substance use and gang involvement and gun violence, right, like they were talking about all of this, we built that into the intervention too, showing how a decision to either, stay inside and listen to some music or go and hang out with people who are engaging in some things, that could get you into trouble or put you at risk, and what those end results might be. It was a psychoeducational intervention, so we married sort of like HIV, STI information with what we knew from cognitive behavioral therapy and some other fields. And this thermometer activity, they got to see not only the link between what they were feeling and how that could increase their risk for HIV and other STIs, but how to like label and then modify those emotions. So figuring out what their triggers were and figuring out alternatives to things that could either put them at risk or get them into trouble, and then having that plan of action that they could go to. This one here is funny. Does anybody know who's on the bottom left there? Jay-Z and Beyonce, right? So as we're coming up with posters and different things, and they wanted to have them, and I was like, please make it, like for them as a couple, right? Like stay together so that we're sick, because the caption for them was like limiting the number of sexual partners, and I'm like, Jay-Z, please, like come on. But we had 4 key activities that we were emphasizing for how they could reduce their risk for HIV and other STIs. And then with our pilot, we saw increased condom use prevention beliefs, a decreased number of sexual partners, and a reduction in depressive symptoms. So, we were able to have some preliminary effect on our participants. Then we started thinking about, okay, how do we better leverage these academic and community partnerships? So as I'm doing this HIV and STI work, I got connected with a group called the Black Men's Health Initiative. And they were saying, HIV is a concern for us, but what we're really seeing is heart disease. My grandfather died, my uncle died, my brother died. And then we were talking to younger men where they were like, people are intervening older. They're having conversations with people in their 40s and 50s and 60s after heart disease has already developed, but nobody is talking to us in middle school, in high school, right? Like when we're early entering the workforce, so that we don't have to have a stroke, so that we don't have to have high blood pressure. And so from this, we got into more work, again, thinking through neighborhoods, right? Like nobody should have to move from where they live to have better outcomes, but neighborhoods weren't only affecting HIV, they were affecting heart disease and asthma, right? Like that common core where if we can address these root issues and root causes, almost every issue in here that we're passionate about, we can see movement in that as well, and improvement there. So we had focus groups with young Black men between the ages of 18 and 30, where we were trying to get a sense of what were some of the things that were contributing to risk for heart disease. And I'll just highlight a few. One of the things that was just like so heartbreaking was they talked about how these high expectations were placed on them despite limited available resources to do something about it, right? So their risk factors were structurally facilitated, but they didn't have what they needed in place to be able to thrive. So we say, oh, you should work out, but if the community isn't safe to just go out and walk around, or if a gym membership exceeds your budget, right, it's harder to say do those things. Eat healthy, right? How many times have people heard, like, all you have to do is eat healthy? It is freaking expensive to eat healthy. It's like you want a salad, I forget where we were. A salad is like $20. I'm like, for some lettuce and croutons, like just $20? You know what I could get from Wendy's for $20? So some of it we think is personal choice, right? Like people are choosing to do these things, but when things are accessible in price, in proximity, and all of that, choice is being structurally facilitated for them. The other one that I'll highlight from here for us as healthcare providers is this theme of managing healthcare needs against fear, avoidance, and toughing it out. So they were talking about the challenges that they were experiencing in seeking primary care, right? Where it's like, instead of going and being disrespected and mistreated, I'll figure it out on my own. Several, shared stories where, like, let's say if their blood pressure was high and the doctor is like, oh, well, you need to stop eating fried chicken. And this is 2020, right? And this one participant, he's like, I don't even eat fried foods. So the fact that he looked at me and made that assumption is not going to work. And what I want to highlight is there was also agency among these men. So things sound sort of doom and gloom, but they were firing providers who were mistreating them. They're like, you know what? I'm not coming back here. I'll go to somebody who gets me, who understands me, who will treat me with respect. And so that's an area of work that we can engage in as well, and then hold people accountable when we see the foolishness happening, right? If you see someone misgendering someone or making stereotypes and assumptions, call them out. Call them on it, because the more we're silent, we become complicit. Won't go on that soapbox. Keep clicking through. So then, we're designing this protocol to try to see, okay, what are those individual and environmental factors that are contributing risk. But we got to that from our preliminary work, from our knowledge, of the literature, but then also from the voices of our participants. And we used that to create this really comprehensive protocol where we were getting a physical exam, so like lipids, A1C, blood pressure. We brought in the mapping side so that we could see the activity spaces where they traveled. Anybody here doing like more spatial work or things where you're looking at the influence of neighborhood or environment on health? Okay, yeah, so one of the advances that we've had, as you're probably familiar, is residential address doesn't really give us a complete picture, because outside of the pandemic, how many of us are always just home, right? We're going to the grocery store, we're going to, faith institutions if we have them, we're running kids all over, whatever that is. So in activity spaces, we can see what people's true exposures are, and we ask those questions as well as doing like our real-time tracking. So by having this comprehensive protocol, one of our undergraduate students came up with this as well. She was like, Dr. B, this study has a lot of moving parts, so let's do an infographic where we walk our participants through a journey of what their time in the study will look like, and then that way they'll know what they need to do when, where they need to be. And so again, the beauty of engaging our students in our work and our communities in our work is powerful, right? And so then we were able to tie that information to their activity spaces and use Google Maps to look at those areas. Before we would have done the in-person audits, in-person environmental audits, but that is very time and labor intensive. And so there are some limitations to using Google Maps, like when the images we're taking, how current it is with the data that we're collecting, but it still helps you assess like walkability in areas, tobacco exposures, those sorts of things that we were interested in. And the last program that I want to highlight is we did an evaluation of a boxing program that was running in Philadelphia, and we were seeing that the city desperately needed these anti-violence strategies. We had almost 600 homicides. This year, the numbers are just even worse than what it was before. And so the program was developed in 2021 to sort of address the need for recreation. In the pandemic, right, we saw frustration was increasing. For young people who were being traumatized and abused, they were now trapped in the house with the individuals sometimes who were doing that. And so this was designed to sort of address that. And they met twice a week at a local church where they were getting boxing skill development, mentorship, and peer support. And then by expanding the program, so again, the community has a need. It's not an area that I'm expert in, but these skills and resources and partnerships, right, that I already have, I can bring that to the table. And so my master's is in psychiatric mental health nursing. Any psych clin specs or NPs here? Awesome, yes. So we can bring that into our work. And so I was like, the young people, yes, they need the boxing, yes, they need the peer mentorship, but they are also exposed to a lot of trauma. Right? They are also in this pandemic enduring a lot of hardship. And so let's make sure that we're getting them connected to the behavioral health supports that they need. And so we were able to do that. And for time, I'm going to take us through this a little quicker. But basically what we wanted to do was to provide a safe haven for them, connect them to these much needed services, and then integrate traditionally siloed programs, right? One of the things I said before was the importance of cross-sectorial partnerships. And so for this, we had law enforcement, we had academia, we had faith-based institution, we had behavioral health providers, and usually all of those individuals would remain separate, but by coming together, we were able to do something really novel for the youth we were hoping to support. There we go. There were a total of 151 young people who registered and participated, a total of 210 who just were engaged in at least one session, whether they registered or not. And then we did a sub-study as a part of that for those who would volunteer and were interested, to just try to get a sense of how the program may have been impacting some different outcomes that we were interested in. And so we had 36 who agreed to do that. We followed them over a 12-week period. And so you see here, average age was 15. Most were male and self-identified as Black or African American. What I want to highlight here Almost 6% had an arrest history. You know, we had recent victims of shootings, people who had ever been shot at themselves. This is only 36 kids. So we would like for that number to be 0, right, if we're only talking to 36 people. But so a population that had been personally, right, like within themselves affected by gun violence. None of them reported being involved in gangs, but almost 1 in 4 knew someone close who had ever been involved in a gang, and then almost half, right, 43%, had seen a visual march or other gathering in their neighborhood in response to a shooting. So in our preliminary impact over 3 months, some of what we've seen is less anger inhibition, so they were less likely to suppress their anger, right? Less anger dysregulation, those inappropriate anger responses of like punching a wall, throwing a chair, less depressive symptoms, less repetitive thoughts and behaviors, less violent attitudes toward personal conflict, and less beliefs that it's right to threaten or shoot someone with a gun. So I'm like so excited by this because like in a city where so much is happening, you know, and there's so much doom and gloom, even if it was just for these young people, we were able to make a difference. And if you know anything about, you know, like individual norms and community norms, as we begin to change these norms, then we can start to see broader structural changes as well. We had some other clinically meaningful results. So there were several symptoms that are tied to youth mental wellness. We saw less sleep problems, less inattention, less anxiety, less suicidal ideation, an increase in nonviolent attitudes toward conflict, so talking things out, giving people the benefit of a doubt. And then this last one here, a decrease in their perceptions of their friends' violent attitudes toward conflict. Because again, thinking about those norms, and especially for this age group, what their friends are doing and thinking is going to be important to them. And so they initially had increased from baseline, but then dropped at 3 months. And that's going to be important for us to think through for violence prevention. So what does this mean for you, right? Like how can you leverage the work that you're doing to have an impact? One of the things that we want to do is think about how we can tackle inequities and how we do that in partnership with communities. And as we're engaging community members, we want to think about all the other players that need to be at the table, from clinicians to researchers to educators, administrators, policymakers, right? Like really making sure that we are engaging other disciplines in our work, but that we are also making sure that other disciplines know who we are and what we're able to do, as I was saying to Diane yesterday. So for your work, are you partnered with economists? Are you working with lawyers? Have you done things with urban planners? Are you engaged with school districts and systems, right? Who are those other people that we normally don't work with that we need to be around tables with so that we can really start to make a difference? Because if we don't, what are people doing? They're getting sick and they're dying unnecessarily. And so lastly, this says, I cherish my own freedom dearly, but I care even more for your freedom, right? We're not free until we're all free. We're not well until we're all well. We are not all going to be able to reach our full health potential until we can all reach our full health potential. And so I encourage us to continue to do that through nursing science. And thank you.
Thank you so much for your inspiring words, and I want to have you over for dinner. Let's continue this conversation. How amazing. So we have a microphone that will be circulating the audience for questions and comments. Margaret is our special microphone holder today. We also have quite a few people who are joining us via Zoom who can chat their questions or comments. Dr. Treat Jacobson will read the submitted online questions as they come up. You can just raise your hand. We have one here. Thank you.
First of all, thank you so much for such an inspirational keynote for today. Really, really wonderful. I have to admit, I haven't really thought of geography in an intersectional way. Is that becoming a thing that we should be considering in our research to do more measures of zip code or other kinds of measures of geography?
Yeah, no, absolutely. And this is where the benefits of partnering with other people. So fields like demography, medical anthropology, public health, they've been doing this, right? Like nursing as a discipline, and there are nurses who have been doing the work as well, but as elevated as it is now for us, we're kind of behind the 8 ball, behind the curve on that. And so I think we absolutely, you know, just as, let's say you discharge somebody from the hospital and we need to know, do they have steps, right? We ask that question. We also need to know the condition of the neighborhoods that they live in, because we have data that shows that zip code is more predictive of health outcomes than some individual beliefs and behaviors. So I would challenge us to say we absolutely do need to bring in a geographical focus to our work.
Thank you. And follow up, do you have recommendations in addition to zip code, what we should be thinking about as these measures?
Yeah, no, excellent question. So zip code is going to be a very large unit of analysis, and even if we drill down to census tract or block groups, those help us from an administrative unit perspective. So if we're trying to get secondary data from a local health department or those things, that'll typically be how it's released. When we talk to communities, though, they don't necessarily identify with the administrative unit, right? It's like for Philadelphia, they'll say like, I'm from Germantown, I'm from Nicetown. And so there are ways where you can find out from people what the boundary markers are. We even had our participants draw what they consider to be their neighborhoods. And then you can, back from that, tabulate either using, you know, blocks, block groups, census tracts to compile neighborhoods that then make sense for the population that you're working with. Yeah.
Thank you. Thank you. That was an incredible presentation. It really hit home with me. So for a number of years, actually, when I began my career, it started out as just doing exercise programming patients with vascular disease in community settings.
Yeah.
Well, I realized that wasn't enough, so we had to expand on that, do more like community-based participatory research, you know, engage the patients, seek their experiential knowledge, right, to see it through their lens on what's important when we develop these programs, you know, for them to try to improve their health. And we've done some things with like, you know, built environment surveys like PRC HAN, Google Maps to try to determine best areas in their environments, where they're living, where they're working to, you know, again, improve those exercise programs for them. And we partner with a number of people. But one thing that really kind of set with me, and I wanted to kind of get your take on, is bringing that concept to them. We know exercise is important. It does all these great things if you can actually do it. So I guess how do you enhance what I'm already doing, or for lack of a better way of explaining it, reverse engineer, and then hopefully to seek and improve even further than what we could have done going the route that we are?
No, that's an excellent question. And so if you're familiar with the concept of motivational interviewing, right, where you get the buy-in from the individual, it's sort of like that. With these focus groups, it ended up turning into that process because there were men in the groups, let's say, who were less active or were not eating as healthy, and then other men, because like I'm thinking one in particular, his uncle, I believe, had died. And then when at that funeral, him, some other uncles, and some other relatives started a steps challenge. They went out and they got Fitbits and they were like, look, we don't want this to be the end of our story, so let's do something to get moving. Or they talked about how, you know, their meals, they weren't always preparing their meals themselves. They had people that they were dating or parents, you know, or like they were just buying things. So if you can have members of the population that you're working with to go to them to say, hey, this is what we're seeing. How do we now get the messaging about this out in a way that is culturally and contextually relevant, right, that like makes sense for the population? So I think you can present the ideas that you have and then have them, we're doing a knowledge translation project now down at the University of Louisville, where we have community advisory board members, we reviewed the literature, figured out some strategies, and now we are like putting it to them to say, what does this look like in public health messaging? Is it billboards, is it radio ads? What's the language of that? So I think that might be one way to do it. And then thinking through, the other thing that they helped us with is they were like, you know, everybody, the gym is always the default, but if we can't go to the gym, one guy, he's like, I can just work out in the house. He's like, I go up and down the steps for 10 minutes, I do 50 push-ups, you know, I do some squats, so even if you don't have like the internet access to, you know, get to some programs, or they talked about YouTube things. So I think we can help people think outside the box to work within the resources that they have available to them, while we at the same time fight for them to get access to the resources that they should have.
Yeah, I completely agree. So I'm defining community as a disease, but there's so many different individual differences,
Yes.
if you will, and troubleshooting almost,
Yep.
but still applying it to the larger group. So thank you. That was great.
Yeah, thank you for that.
Well, I have an online questions from the
Okay.
chat. So I'm working with a group trying to understand what is preventing families from getting their pediatric PCP on time for childhood vaccines. You mentioned joining with people that are the populations we are reaching out to. As a white female, how do I approach caregivers to join with us? I do not want to come off as that entitled white lady nurse.
No, excellent question. So one, and soapbox, remember it's me, it's not your leadership. Acknowledge that, right? Like whether you look like the population or you don't, acknowledge that we are different from the people that we're trying to serve. Because even as a Black woman, right, I have a doctorate, I'm a professor, I'm in a different income bracket. My lived experience is very privileged now, right? Wasn't in Brooklyn, but like very different now than some of the populations that I'm working with. And so I think the humility, it's not cultural, you know, all these other things we call it, it's humility, being humble enough to come in to say, this is what I'm seeing as an issue. Is it a problem for you? And if it is, how do we work together to do something about it? And so in that example, they can say, you know, we've noticed that pediatric providers are struggling to do X, Y, Z. Here are some things that we've been thinking about for how that might be able to be improved. Does this make sense to you? Is this something you'd be willing to do? These are the resources that I have through the University of Minnesota at my disposal. Would you want to partner with me on my team to get this done? And one of the things I didn't mention today, when we engage partners, we don't want to just do that in name, right? We also want to do that in power and in decision making. So having individuals on your co-investigative teams for your grants, not just as a consultant, not just as a, oh, this is free, let me pick your brain, you know, paying our community advisory boards, all of those things. So what we have found is gender and racial and ethnic concordance don't always matter. It is about the person knowing that you genuinely care, that you're invested, you're not trying to make a name for yourself. You know, what we get accused of as researchers is like swooping in to get the information and then we leave and they never get anything as a result of it, you know, and they're no better off than when, like before we came in. So even to answer that question, even if you can outline a plan for what you want to do, right? Like, so with this information, we now want to try to change practice so that this can happen, so that that can happen, and then they'll also be able to sort of like see and have that buy-in that not only are you bringing them to the table with you, but you want to do something with your data that can help to make a difference for them. Excellent question, thank you. Margaret,
up
I
here,
think we
front.
have. I think it's up.
All right, so first of all, thank you, Dr. Rice. Amazing presentation, and your work is so meaningful, so thank you for that. I was wondering, I know this wasn't really part of your research aims, but with the Project Gold, as somebody who's kind of looked at unintended pregnancies and reproductive justice, particularly in this time where access is getting very limited, how your adolescent participants, how they kind of talked about the experience with reproductive health and the consequences of sex.
Yeah, so we are fortunate that the Philadelphia context compared to some other areas in the nation is a very liberal environment. So like even for the state of Pennsylvania, young people can access sexual health services on their own in their teens. So their experience may be skewed compared to youth who might have lived somewhere else. So we didn't have anything. Like they could get access to birth control pills, they could get access to condoms. Our aid service organization, Department of Behavioral Health, like there were a lot of entities that made resources available to them. We even have mobile van technologies where they were like riding through communities, doing testing, you know, providing resources. So ours, we weren't hearing challenges, but I guarantee you that in some other areas there are young people who are having to do things in secret, behind closed doors, not able to get access to what they need. But that's where even youth, treating them as the expert of their own experience, right? And talking to them to say, hey, this is what we're seeing. What is your experience, and how can we now come together to get you what you need? And our data is what is informing policy. Our data, and being able to put that in a palatable way that makes sense to lawmakers, that makes sense, right, to the individuals who we want to be able to do something about it. So I encourage us to continue to keep that and collecting our data with our end users in mind, right? So I would love it if people cared that people were dying. That doesn't move everyone. But if I say, you not doing this is costing you $3 billion a year, guess what they're gonna do? They're gonna start doing that thing that's only gonna cost them maybe $1 million, but thinking that through as we design our studies and collect and disseminate our data. Thank you.
Okay, I have another question.
Yes.
There's appreciation for the slide on equity and justice, and this is the tricky one. What strategies have you found to be effective at moving the tree, to bend toward justice? And we'd all like our work to do that, but how?
Yeah, that's an excellent question, and that is sort of the phase of my career that I'm in now. When we talk about fixing systems, I think, and I absolutely love my dean. I have a wonderful relationship with her, and so for my school to have entrusted me, right, to now be the Associate Dean for Research and Innovation, that's a privilege, as you know, a position of privilege and power to the next level. And so being able to partner with people and look at proposals to say, have you considered this? Right? Have you thought about policy implications of your work? Okay, I'll use the transportation example again. Yes, you can get the person to the health center, but what do we do to fix the fact that that health center is not providing high quality care? So I think as we look at the really root causes that are driving the issues that we want to address, the key for me is going to be changing policy, right? Changing who has access to what. How many of you, I love asking this question, I can't wait to see how it happens. How many of you would consider yourselves to be socialists? I love it. If you could see from up here, people go like this.
That kind of turn there.
Yeah, you're and I'm not 100% a socialist, but I do believe in the redistribution of wealth and power and resources, because without it, we're going to continue to be imbalanced. And so I think even using our work to say who has historically been without, and how do we do reparations for that? How do we get to people what they have not had, and doing it in a way that can help to improve health outcomes? So we as nurses can do that in our work too, but I would say the biggest way is thinking about what we can do to change policy, because policy is driving praxis, right? Policy is driving how healthy people are, how sick they are, and that would be one of the ways to work toward justice. And then acknowledging that it is going to cost us something, right? To change this broken system, to change the system that is doing exactly what it was designed to do, it is going to mean something for us. It may mean less research funding available. It may mean people who historically were not getting funded now, which means some people who have had, $200 million are no longer getting those grants. But in the end, the science is going to be moving to where it needs to move so that we can address and tackle health inequities. And we have a hand. I feel so bad for you. She's right as the sun shifted.
Where I'm I want to sit there. We have time for one more question. Thank you.
I said I feel like a cat in a sunbeam.
Yes.
I love everything you've had to say. I feel like I'm soaking it in. So I have a somewhat unique role. I work in data quite a bit, but I work with brokers and employers. So my passion is all around kind of helping employers to understand the social determinants of health. And so I go quite a bit into community health rankings, food insecurity data, pulling down those CSV files by zip codes where the employers live, and help to inform employers about just how the lower paid employees are really oftentimes living in their cars or maybe one rent payment away from that.
Yeah.
And what that means to them and how health benefits, how it shows up and how they use their health benefits. And I think part of the problem is, and I think there's groups out working to do to repair for this, is social determinants of health are really not assessed in the site of care for medicine.
Yep.
I think there's, Prepare is one assessment tool that's being used in community centers, in some of the community centers where there is abject poverty. But if we're trying to truly measure in a clinic setting, what is the impact of housing, gaps in housing, gaps in food, gaps in personal safety, we have to start to measure it so that we can measure it in a medical claim system.
Absolutely.
Right now, we have to go to this, we have to go to the community health rankings, we have to go to this food security measure, we have to go by zip code, but it's not at a person level. Until we can measure a person's health and well-being by where they live and put it all together so that 80% of that clouded social determinants of health is all mystery, it's going to be really hard to get people to invest in it.
Yeah.
Unfortunately, I wish that wasn't true, but I'm doing it kind of piecemeal and kind of in the way that you are in informing employers, and their eyes are wide open. You mean my employees don't have places to live?
Yep. Yeah, no, thank you for that, because it goes back to that earlier slide about shining the light of truth, right? We have to have the data to say that these things are happening, because it's one thing if you walk into a room and you say, oh, X, Y, and Z is an issue. It's another thing if you walk in and you say, I have data on 20,000 people in your, in your constituency, in your community, in your hospital, and this is what those data show. The National Institute on Minority Health and Health Disparities has a FAAN toolkit, PHENX, and then toolkit, and they are universal measures that get at some of the social and structural determinants that you're mentioning. And so I think, on the one end, we can integrate that into our research, but we absolutely, through policy, need to have these be standardized as part of the patient encounters, right? Like, I'm thinking about, we had done a study, and it was like partnering on something related to asthma, and the question asked, do you have a cat? And the woman said no. But then she's having like all these asthma flares, and you find out there is a cat in the house, but it's not hers. So she doesn't have a cat. Her brother has a cat, but her brother's cat is like just flaring her asthma. So something basic from saying, do you have a cat, to is there a cat in the home, right? As we're thinking about data, as we're thinking about, what we ask our patients and how we're engaging in the clinical and even other settings, we want to make sure that we're asking the right questions and that we're doing that in a comprehensive way so that we have the data to bring about the changes we want to see.
Our last question.
I guess we have one more.
I think it's off.
Now, yep,
There we
that's
go.
it. Thank you so much for that presentation. It was really fascinating, and it reminded me when you talk about engaging the public in creating your question as well as the solution or the intervention of it and the conduct of the research of a project we did at Washington State University, and that was right when there was a lot of publicity about high reliable organizations. And if you look at that information, a lot of it was derived by non-healthcare providers and really industry-driven parameters, and not necessarily from the patient's perspective. So they were telling healthcare workers exactly what you should do to create a highly reliable organization, and all these safety things about falls and pressure injury prevention and all that. And yet we have all these falls that were occurring. So we started asking ourselves, what do patients know about falls and why we're doing this stuff? Instead of us dictating to them, you have to stay in arm's reach, you have to wear these socks, you can't get out of bed without us being there, we have to turn you every 2 hours. So we created a study where we looked at, what do patients know about these things that we try to do? Do they know about falls, the risk of falls? Do they know about pressure injuries? And we had included some healthcare providers in the focus groups that we conducted. And we were amazed at how much people didn't know, the public didn't know about the injuries and the harms that could come being in the hospital. And by engaging them, and yet staff felt like they were doing all the right things, telling them do this, do that. And then when we engaged them in the conversation, then we could start talking about, well, what are some things we could do to help you understand the risks so that you could cooperate with us in the hospital to reduce your risk of all these complications. And so many of them thought that they were doing the right thing by trying to be as independent as possible, but in fact, they were increasing their risk of pneumonia or they were increasing their risk of injury. And I think that really underscores how we have a lot of assumptions about what we do. We're in charge of taking care of these people, when in fact, if we engage them in the conversation, we get a whole new lens on what the real experience is like for them.
Yeah, no, that's excellent. And really what that is our savior complex, right? Where we're like, we know what to do, we'll come in, we'll get it done for you. No, they know, right? It's their experience. And then even, and it goes back to what you were asking before, even then if you're able to say, like, we talked to other patients who were at risk for falls, or we talked to other people who were struggling to build exercise into the routine, and this is what they said. And having direct quotes from people, then it's like, that sounds like my language, that sounds like what I'm experiencing. Oh, I'm going to try that. And I love the language that you use of, like, you know, partnering with them and engaging with them, and, you know, we can co-build things together, but that's where we'll really see buy-in and change, by bringing them to the table with us. Yes.
What an excellent conversation. So can you join me in thanking Dr. Rice one more time for her excellent contributions.
Aw, thank you. Thank you.